Mr. Speaker,
Order. Questions for oral answer. Ms. Evelyn.
Question 1, sir.
First of April 2022 to the 30th of September 2022, there were around 330 reported cases from COVID-19 clusters in hospitals. Over the same period, around 3,000 COVID-19 cases were reported by the nursing homes. These constitute a small proportion, less than 1% of total reported community cases. As we move towards living with COVID-19, we no longer adopt a zero-COVID posture in hospitals and nursing homes where all patients or nursing home residents need to be tested before admission and where infected patients are isolated in hospital COVID wards. Notwithstanding these measures, we continue to take necessary precautions to protect patients and residents and are ready to step up the COVID-19 measures such as visitor restrictions when necessary. Vaccination is our primary defense. It cannot completely stop infections, but is very effective in preventing severe illness from COVID-19. We have provided COVID-19 vaccinations to over 90% of eligible nursing home residents. With these measures, we have kept Singapore's overall case fatality rate at about 0.1%, well below the global average of around 1%. Thank you, sir.
Ms. Evelyn.
Thank you, Speaker. I have 3 supplementary questions for the Senior Minister of State. Earlier, he cited some figures about patients and residents who had contracted COVID from within these facilities. I think he mentioned 330 in hospitals and about 3,000 in nursing homes over that period of time. May I ask him how confident is he that these are not underestimates of the actual situation, because some patients could be asymptomatic and I'm not sure whether there's 100% testing daily. So that's the first question. The second question is that there are some studies in the UK which suggest that within healthcare facilities, patient-to-patient transmission was a more common cause of infections rather than, say, from healthcare workers to patients. So I wonder whether the ministry has been studying this issue and whether he can elaborate on whether it is the case that it's more likely to be patient-to-patient transmission rather than healthcare worker to patient, or whether the ministry has some other grasp of the nature of the transmission. And finally, I understand from some other overseas studies as well in the UK that hospital-acquired infections may be affected by things like ventilation systems and design of wards. So is the ministry looking into these matters as well?
Sir, the numbers may be an underestimate. We did not do daily testing on everybody. I think the member would agree this would be inappropriate to subject every person within the space, whether a healthcare worker, a patient, or a visitor, to daily testing. We took a risk-based approach within nursing homes and hospitals, as we did within the community, and in different locations, under different circumstances, the risks changed. And so we did a risk-based approach on testing. Having said that, we have quite a lot of data over the last 3 years, and that data is applicable to the community setting, the hospitals, as well as the nursing homes, which have allowed us and the scientists in our system to model the transmission and the clusters and the spread of COVID-19 within different settings. So yes, to answer a question, it may be an underestimate, but I think we are confident that we have a robust handle on the relative proportions. So it is approximately correct, 330 versus 3,000. I don't think our underestimate is so far off that the numbers would be reversed, for example, or that we're an order of magnitude or a significant percentage off. We are about right, and we have some confidence that we are about right. Her second question was whether patient-to-patient transmission or healthcare worker-to-patient transmission, which was greater contributory factor in our setting, in our system. I don't have the data in front of me. Remember, I would encourage her to file a separate question if she would like further information of that. But if I may make a related tangential point, which is that the COVID-19 circumstances changed quite significantly over the 3 years. Simplistically, we had different variants with different transmissibility and infectivity characteristics, but we also had very significantly different measures in place at different time periods over the nearly 3 years. So I think it would be too much, too reductionist and too simplistic to look at the overall picture. This would require quite a detailed study to be able to come to a conclusive position as to which was a greater risk at any one point in time. I think a little bit too simplistic to say it's one or the other. But I'd be happy to take this up if the member would like to file a question, and we'll try our best to provide her what data we may or may not have. Her third question was whether the design of the wards, the ventilation, can affect hospital-acquired infections. And indeed, these are things that have been studied. Actually, prior to COVID, there are people looking at this, and looking at this not with respect to just one infection, but a wide variety of infective agents which may affect our patients within the hospital. So the short answer is yes.